Yes, well, from today's session, what I was hoping, Dr. Atika, was really to share with people my sense. I have the privilege of working in many countries, and it was really to give people a sense of what's happening globally in healthcare. And of course, some of that will apply to India, but it will also, some of it will be, you may think, oh, that's not quite the case in India. So it's it's going to be very global, and it'll be helping, I hope, the participants on today's webinar to really get a sense of where healthcare is going. I mentioned to you just before we started that I had the privilege of being in India last week, and I delivered a talk at the Quality and Safety Conference for Apollo in Delhi, and also had a chance to tour parts of your beautiful country. And it was a great joy for me. So I hopefully that will inform some of my talk today. I still have that Indian spirit in my veins.
We are very happy that you liked what I know that you visited the Agra and you've loved the monument there. So I'm very happy that you had a great visit over here. So we all are looking forward for the session. We'll give another 1 or 2 minutes, Doctor. Or you want to share your screen till that time? People will be joining us.
I'd be very happy to do that. Let me go share screen.
So if you have any doubt or you want to ask anything particular from Dr. Mark, please write it on the chat box. We'll be taking the question at the end of the session.
Well, terrific. Well, thank you again, Dr. Atika, for the invitation. I enjoyed the first webinar where we looked at the personal journey of leadership. But this is a little bit more managerial, if you like. This is looking at how we actually do our jobs as leaders, and particularly the environment or the framework within which we operate. And as you mentioned, let me see if I can get my slides working. As you mentioned, I have a number of roles which I really enjoy, both in Australia and in the United Kingdom. And part of my work allows me to visit many countries, and I suppose what I'm going to share with you tonight is informed by my work in a number of countries. So when we start to think, we talked in my last webinar about the personal journey of transformation, but I just want to remind you that, the job of a leader is to create value. A job of a leader is not just to sit and watch while things unfold. We have to think about how we drive the value equation, which is how do we improve quality with the resources that we have. And my own personal view is to do that, you really need to understand the ecosystem under which you're working. And that's why I think understanding the global megatrends that will affect healthcare in the 2020s, I think is critical for leaders. And as you know, a few years ago, we had this thing called COVID-19 that came across the world. And I'll return to a model by a little later on that explores the relationship between simple, complicated, and complex work. But what we saw was an uplift in complexity. Things that were simple before COVID suddenly became quite complicated. Work that was complicated suddenly became complex. And in some places and in some parts of the world, the complex work of managing a pandemic at a public health and at a service delivery level actually became chaotic. And so I think it's fair to say that while hospitals generally across the world have performed well when people got into hospital, I think many health systems have been found wanting by the limits of their public health response, or indeed their ability to mobilise both government and non-government forces to protect their population. But of course, now we're emerging into an era which I've optimistically called post-COVID, but I'm sure everybody online knows that we haven't seen the end of this pandemic yet. But we're hoping, I suppose, that things continue to improve. And I have a lot of points on these slides, so I'm not going to go through them every one in great detail, but it's rather to give you a general sense of what I see are the challenges and the megatrends post-COVID in a number of areas. And I'm going to start off with policy. You can't go anywhere in the world without people talking about our need to reduce our carbon footprint. And healthcare typically accounts for about 8 to 12% of the carbon footprint of a country. And so we have a major contribution to make in reducing carbon dioxide emissions and whether that be in laboratories or whether it's would be in hospitals. And so I think there are many policy minds talking to the challenge of global warming from our emissions point of view, but also the fact that across the world we're seeing increasing extremes of weather. And of course, this means that we are going to have, particularly for elderly people, a lot more exposure to extreme weather events, particularly heat. I think we're seeing a global trend of patient experienced or influenced service design for value. Everybody is spending a lot more money at the policy area and a lot more thinking, mapping the patient journey from initial engagement with the healthcare system right through to discharge in hospital, or in the case of primary care, right through to end of life. And I think we're going to see that as that patient journey gets mapped and modified, that funders will start paying for outcomes on that journey rather than just simply for services provided. I think the pandemic also taught us that it's absolutely critical that we integrate healthcare. A great hospital system is not the same thing as a great healthcare system. And whether that's public health, primary care, aged care, hospital in the home, or telehealth, all of these things are an integral part of a modern healthcare system. And so governments and policy developers are working hard in that space. I think we're also going to see increased governance over the non-technical performance of the industry. I referred to this in my last webinar. While we have achieved amazing technological advances, we have some behavioural and communication and leadership deficits in our industry that I think increasingly governments and policymakers will seek to influence and change. I think there'll also be a really interesting policy development around innovation. I get a little worried when I hear people talk about healthcare innovation, because sometimes I think people are talking about innovation as an ends in itself, whereas innovation is simply a mechanism to get to a agreed value creation output. And so I think we need to think at a governance level and at a policy level, we need to be thinking about what are we trying to achieve with innovation, not just how do we do innovation. I think in some countries, we're going to see an enhanced and expanded role for public health. I think the pandemic showed that there were some policy deficits around public health responses. And, you know, many epidemiologists and virologists tell us that we will continue to get, particularly with climate change, more and more public health challenges. And we need to perhaps ramp up the expenses and the funding and the expertise that we allocate to that. And I think every country that I'm working in sees an interplay between government-provided services and private-provided services, whether that's funding or delivery or risk transfer. I think we're going to see a re-examination in many countries of the role of the private sector and how the public sector interfaces with that. From a healthcare economics point of view, I think the biggest trends will be a shift away from pay-for-process to input-based budgeting to perhaps funding for value. In other words, funding being linked to results rather than just simply throughput. I think one of the other things that we've seen across the world, particularly with things like supply chain interruption and healthcare workforce shortages, that we're going to see a one-off uplift in the cost of healthcare delivery in many countries. Experts suggesting it could be as small as 5% or as high as 20%. And many funding models haven't really adapted to the fact that we may be facing this significant one-off uplift in healthcare inflation. I think that healthcare inflation will accelerate the shift of care away from hospitals to primary care and community-based services, which are traditionally cheaper. And I think there will be greater scrutiny in many countries of high-cost treatments available to only a small percentage of the population. Some of you would be well aware of the PROMs and PREMs terminology, PROMs being patient-reported outcome measures, and PREMs being patient-reported experience measures. And we're already seeing in some countries these measures being utilised to influence funding and to shape the way in which the patient journey is remunerated. I think in many countries, the challenges of scale will see consolidation in private sector providers, whether that's private sector in areas like pathology or radiology, but also in hospital groups and in primary care and community care. As I say, I'm not convinced yet that reducing supply chain risk has been priced into business as usual in healthcare going forward. And I suspect we have some significant healthcare inflation that is going to come in the next 12 months that is going to test funding models in many countries. And I think this will also shine a light on the systemic cost of error. Depending on the system, there are studies that suggest anywhere between 10 and 20% of the money we spend on healthcare is actually related to error or inappropriate care. And we might find as inflation gets built into healthcare and the shift for pay for value, that this systemic cost of error will start to be accounted for at a healthcare economics level, leading to reduced funding for those who can't provide safe care. You don't need me to tell you there's a massive shortage of healthcare workforce across the world. And it was really pleasing to hear on my recent trip to India how well India is actually planning for this workforce shortage by significantly increasing the scale of its training of doctors, nurses, and other healthcare professionals. In fact, this is going against the trend. The WHO has showed that the vast majority of countries are grossly undertraining for the workforce they will need in 10 or 15 years' time. And so I think we're going to see an incredible mobility of labour across the world. And this will also lead to increased cost as countries enter into auctions or bargaining at higher wages and conditions to attract healthcare workers. I think if you are a doctor or a nurse, there's probably never been a better time to argue for a pay rise in most countries across the world. And this, of course, will add to healthcare inflation and increase baseline operating costs, such as infection controls, staff attendance reliability, and also the cost of training and development. I can't give a talk anywhere without people asking me about the digital ecosystem. And I want to highlight that I'm not a digital expert, but I do have the privilege of listening to digital experts and thinking a lot, both in my roles as an educator, but also as a board member, on the cost-benefit equation of the digital ecosystem. You would know in India, Apollo is already doing remote delivery of care, including monitoring. And this is a trend that is developing rapidly across the world. There's also a huge piece of work about restoring or allowing or enabling patient access to system data, and particularly the control of that data. So patients being allowed to govern who actually accesses their data. And this is particularly important given the fact that we've had significant cyber breaches in healthcare record systems across the world. I think this is going to shine, these cyber breaches are going to shine a light on the governance of healthcare data, both the storage of it, the purity of the data, the single source of truth, and how we control access to it to make sure that it doesn't fall into the wrong hands. And I think at a board level and an executive level, organisations need to determine the appropriate risk appetite they have and the extent to which they're prepared to fund the combat efforts against cyber threats. I know as a board member myself, the cost of combating cyber threats to hospitals in my country is eye-watering. We could literally spend 10 times as much money as we do and still not be guaranteed that we would be safe. And so boards and executives across the globe are wondering, how do we get this balance right? How much do we spend on combating cyber threats? And what is our risk appetite for a breach? And as I mentioned earlier, I think there's also a key piece here in ensuring that any digital innovation is actually business-led. In other words, business need-led. In other words, that we're not just doing digital innovation for the sake of it, but there's actually an output that actually creates value for the patient and for the system. I think we're going to see a lot of analysis of how telehealth has contributed, but also perhaps analysis of some of the risks and challenges with telehealth. When is it, we don't really know yet, when is the right time for someone to see a healthcare professional face-to-face, and when is it appropriate and safe to deliver it through telehealth. We're getting some ideas, but I don't think anyone across the world would say that we know exactly when a telehealth isn't and is not appropriate. And I think also we'll be thinking about how we can use the digital ecosystem to reduce the cost of system error. As I mentioned in the previous slide, I think we're going to come under increasing financial pressure in many healthcare systems, particularly as I predict healthcare inflation will increase, and the digital ecosystem can help us control that cost of system error. I think also linked to the cybersecurity threat, we're going to need to see design features as part of innovation. Often in the past, I think digital platforms and apps have been designed without much thought about how secure they are. And I think this is particularly the case as we move to cloud-based services. Theoretically, these should be safer, but what would be the impact of a major cloud-based service going down should there be multiple cyber attacks, perhaps during some sort of military threat or some sort of political instability? And so I think there is still a lot of work to be done as how we build security as a design feature on all the digital innovation. And then, of course, on the exciting side, there is the enormous potential of mining big data. And I think this is going to create an exciting wave of innovation and findings independent of the traditional research methodologies. The ability to find correlations and indeed proof that particular medications and or conditions are impacted at a system, at a global level from massive data systems will lead us to new treatments, to new ways of diagnosing and managing disease. And I think that means that COVID will inevitably accelerate the pace at which machine learning and artificial intelligence is and will be utilised in the future for technical innovation, for research, but most importantly, as I've alluded to, for financial reasons, business process optimization. And I think for clinicians, there's going to be a challenge here. I think many doctors and nurses really value the autonomy that they receive as professionals. A hallmark of professionalism is a strong level of autonomy when it comes to decision making. And I think artificial intelligence has the potential to challenge that. When algorithms become more predictable than perhaps professional judgment in some areas, or perhaps when a pathway is shown to be scientifically superior to the autonomous practice of clinicians, then I think we're going to have to really start having some very serious conversations about to what extent should we let clinicians be autonomous, and to what extent should we actually allow artificial intelligence to actually influence the pathway of patient diagnosis and treatment. I think when it comes to insurance and indemnity, this is going to be very interesting. I think it's going to vary from country to country. We're also already seeing in some countries huge contribution increases and co-contributions increases, which is actually creating a risk transfer from private insurance companies and reinsurers to government treasuries, in a sense, bringing insurance away from the private sector and into the government sector. And this creates a whole lot of policy and funding challenges that in some countries will be novel to doctors and to healthcare systems. I think we're already seeing health insurance exclusions impacting on tourism. If you've tried to travel recently, you'll notice that many travel insurance policies that people try to purchase have significant exclusions around COVID and increasing co-contributions or upfront costs should you actually need to call on that insurance. I think countries are looking at the costs of treating non-residents and how they recuperate that cost from insurance companies. And indeed, I think many countries are examining reciprocal healthcare arrangements. The costs of providing healthcare from government treasuries to visitors to a country was very significant as people moved around during the pandemic. And if we believe our virologists and epidemiologists that we are likely to see increased numbers of pandemics and epidemics as climate change impacts our globe, these reciprocal healthcare arrangements may also come under scrutiny. As a board member, I think, and particularly for those of you who sit in executive positions, there is this whole area of corporate governance that I think has been impacted by the COVID pandemic as well. I think certainly at the board table, I think business continuity and disaster management discussions have really been ignited in boardrooms across the globe. I think supply chain security, talent recruitment and retention are also top of mind for most healthcare boards across the world. As I mentioned earlier, the cost of cyber risk is eye-watering, and I think so much so that higher levels of data security have to be normalized into healthcare, and this will probably come not only at cost, but significant inconvenience to patients and perhaps even to patient-facing carers and healthcare professionals. I think there's a global consensus that we need a lot higher levels of operational agility to meet the post-COVID environment, but I think again, we're struggling how to quantify the value of that innovation that is occurring. We know that value is being created, but what is particularly creating value, what is not creating value, I don't think we've got the metrics around that right yet. And as I said, I think the costs and deductibles of insurance renewals are forcing many organisations around the globe to bring financial risk back into house. And I think this runs the risk at the board level and the executive level of reducing organisational risk appetite at a time when many directors believe that innovation and risk-taking is needed. So I think there's quite a challenge there. In the area of clinical governance, I think it's very hard. I think it's too early to say whether the pandemic will help or hinder the drive from so-called safety 1 to safety 2. Safety 1 has been the traditional approach to clinical governance, which has been to look at what's gone wrong to see how we can fix it. Safety 2 is much more positively focused on what is going right and how do we actually ensure that we promulgate or spread what's going right across the organisation. Quite a different approach to looking at what's going wrong. And it's not that one is better or worse than the other, but rather we need to have a mixture of both. And prior to the pandemic, there certainly was a movement towards a greater emphasis on safety 2. I'm not sure yet whether the pandemic has helped that or whether it may have slowed that transition down. Certainly, we know that across the globe, there was a lot of encouraging signs as we saw emergency departments, hospital wards, primary care clinics innovate and introduce rapid cycles of improvement or ways of working and driving a shift of focus to what works well on a daily and weekly basis, in contrast to what many felt was healthcare's inertia at responding rather slowly. I think if this push to value, particularly at a health economics level, does occur, I think that we will get better quality and measurement of lead indicators of safety. And I think, as I've mentioned earlier, I think the healthcare inflation and this value equation being driven will lead us to address the costs of unwarranted variation amongst clinicians, amongst services, between organisations. And I think this has enormous potential to prevent patient harm and reduce costs. I think on the longer term, it's harder to predict what the impact will be. In many countries, doctors and nurses in particular are reporting that they feel burnt out after the COVID crisis. And we have in many countries, particularly in nursing circles, nurses leaving their profession and taking up other roles because they felt unsupported or they feel that their work is not valued compared to other vocational opportunities in their society. I think there will be more breaking down of silos, particularly between doctors and nurses. But I also wonder about whether we will create a more open and speaking up culture or whether the pandemic is less likely to lead to that. I'm optimistic that we're likely to see more speaking up, more addressing of problems and challenges in quality and safety as a result of the pandemic. But I think we have to wait and see. So, as Dr. Ratika said at the beginning of my talk, my job is, one of my roles is to be the leader of the Oxford Healthcare Leadership Program. And obviously, I've had to think a lot about how we prepare leaders across the globe for these megatrends and how they respond. And so, as I mentioned last time in my first webinar, we thought the personal ability to lead transformative change was really important. But we have particularly focused on the need for a state-of-the-art understanding and insights in how you discern successful strategy in this rapidly changing landscape, how you master the digital and technological transformation space, how you adapt to the future business of healthcare, how you improve individual and team performance, and how you successfully drive innovation. And these key themes of the program I lead at Oxford were informed by some interviews and some focus groups that we did with healthcare leaders across the world before the pandemic, and then, of course, shaped by our experience and the feedback we've received during the pandemic. And I believe, my apologies, that was Siri. My belief is that these 5 areas of technical expertise, which we'll be focusing on the program that I lead, are the right ones going forward for the 2020s. I think as I thought about the key outcomes of the program I lead, like I spoke last time, I think we need wisdom, knowledge, and skills in leading colleagues through an enormous period of change in the next 7 years. I think we need to focus on preparing our teams for the world as it will be, not as it currently is, and that means we need to be thinking differently. I think we need to all increase our level of sophistication in our understanding of how the healthcare system actually works, and I'll say a little bit more about that in a minute. And I think at a strategic level, we need to make sure that we're not defending things that are no longer relevant or useful, and we need to move where the action is when we start defining strategy. One of the professors of strategy at the Said Business School at Oxford University has done some very impressive work on what is called diligence-based strategy. And in this work, Professor Powell highlights that one of the most important predictors of strategic success is focusing resources on underperforming parts of the business or team. And he challenges the assumption that underperformance is additive, whereas in fact, it seems to be multiplicative. In other words, the best predictor of strategic success is often looking at those parts of your organization, your team, or your system that are underperforming and allocating resources to them. And as you get an uptick in performance in those underperforming areas, that impact multiplies throughout the business. And I think we need to be asking ourselves, what are we trying to deliver? What is going to be our response to the megatrends over the 2020s? And these, for me, are the things that we should be trying to achieve: a much more respectful patient experience, a much more integrated service to patients so that they don't have to repeat their story over and over again, that they can access the information and the services that they need, either face-to-face or online, and most importantly, asynchronously, in other words, at their own time, if that makes things simpler for them. And of course, in countries like India or my own home country, Australia, access to good care irrespective of wherever they live. I think we need to see a more partnership-driven service where evidence-based decision-making and delivery is designed for consumer needs. And as I've said a number of occasions tonight, I think we need to have a much more transparent value-based proposition. In other words, we need to focus not only on price, but on the quality of care that we deliver. This is an extract from a report of a Royal Commission into a failure of clinical governance at the Mid Staffordshire NHS Trust about 10 years ago in the UK. And I think it's a wonderful summary of the likely causes of underperformance in an organisation. And I'd suggest to you that these findings are common in most healthcare organisations. I think in the case of Mid Staffordshire, they were present to a very alarming extent. But I think that you could go into most hospitals or healthcare systems across the world and see these likely areas of underperformance. And so I'd encourage you to look at this list and to think about whether this applies in your organisation, and if you are a leader, what you can do and how you can use the theory that we've discussed and your understanding of the megatrends to actually address these. And as I said, in addressing areas of underperformance, multiply the effects through your business. Many of you would know this model, the Cynefin model, developed by Dave Snowden some 20 years ago. It talked about decision-making, but I also believe it's a very wonderful model for thinking about the different types of work that we do in healthcare. And what we're seeing in many countries, particularly with COVID, is an increase in the complex work. And I think the important thing about complex work is that the typical way that we have led in healthcare has been in simple and complicated ways. And These are much more like command and control. They're much more leadership focused in terms of leader competence at a technical level. But once we move into complexity, it's a very different space. Cause and effect is not actually straightforward. And often we don't even know what type of care we're trying to deliver as we start, because there are so many variables that we can't actually predict the outcome. Now, typically, this has been normal work for geriatrics, palliative care, and those involved in multi-system chronic disease. But I would argue that the pandemic pushed even complicated work. This is, in a sense, algorithmical work like elective surgery, obstetrics, oncology, and psychiatry into the more complex space as we started throwing on the multi-system chronic disease induced by COVID onto this relatively linear and algorithmical work of radiology, pathology, and, for example, elective surgery. And I think as a leader, it's important to realize that you'll deliver all types of care. In a surgical unit, you'll be delivering simple work, you'll be delivering complicated work, and you'll certainly be delivering complex and complex adaptive work. And in my own view, I won't have time to go into this in great detail tonight, but in my own view, many of the leadership challenges we have in healthcare at all levels arises particularly from the utilization of complicated problem-solving strategies, in other words, algorithmical type leadership on complex and complex adaptive problems. And I think COVID highlighted this. So I think a lot of the poor leadership I've seen across the world has been as a result of simple processes being utilized in complicated work and complicated processes being used in complex work. And in particular, the people change management approach is quite different for each and requires conscious switching. And here's an example of that from a fantastic paper published 20 years ago, but in my view, still one of the best analyses of complicated and complex system theory as applied to healthcare, done by Gluberman and Zimmerman in Canada. And I will give you that link in a minute. But here's an example, for example, the difference between how you collect evidence in a complicated system and how you collect evidence if you're leading a complex system. And for example, in planning, how do you plan in a complicated system and how do you plan in a complex system? And you can see, for example, if you look at the third line down in planning, you'll see in complicated work, decision procedure is seen as an event, whereas in complex systems, decisions emerge typically from group discussion and input from the patient and the evolution of the actual delivery of care itself informing how the decision is made, which is not the case in a complicated system. I hope that's not too confusing, because I'm trying to highlight an area of quite complex thinking in a couple of minutes. But look, I would really like to suggest to you this is a wonderful resource. It's available free on the internet. And it's a discussion paper 20 years ago in Canada on complicated and complex systems. And within this report, which is downloadable as a PDF, you will find some wonderful discussions and thinkings on the difference between complicated and complex system and complicated and complex healthcare delivery. And I think it's terrific reading for anyone who is a healthcare leader. And I believe gives great insight into how you actually solve so-called wicked problems in healthcare delivery. So Dr. Ratika, I'd like to thank everybody for listening to me over the last